English. For those of you who do not understand Welsh, please do the following. Scroll to the bottom of your screen. There you will see an interpretation logo. Please click on that and then click on English. Good evening and a warm welcome to this online public engagement meeting. Welcome to our guest speakers as well. My name is Malcolm Latham and I am the Chair and Voluntary Member of the South Glamorgan Community Health Council, and I am joined by the Chief Officer, Stephen Allen. The Community Health Councils, or CHCs, are the only independent, public and patient-led NHS watchdog in Wales. One of our key responsibilities is to represent the interests of the patients and the public in the NHS. This evening, my role is to chair this engagement meeting and to act as the honest broker in discussions. As a CHC member, I have no preconceived views or opinions as to the proposals being presented tonight. However, I am clear that my role is to ensure that the meeting is carried out in an orderly manner. This evening's online engagement meeting is to discuss the proposals from the Cardiff and Vale University Health Board entitled Shaping Our Clinical Services. The house rules to be followed during this meeting are to help keep the background noise to a minimum. Please make sure you mute your microphone when you are not speaking. If you wish to ask a question during the meeting, you will need to have your video camera on and your name on the screen, unless you are using the phone audio channel. If you choose to use a webcam, please be sure it is in a stable position and focused at eye level if possible. Everyone's view is important, so respect what they say, even if you disagree with them, because you do not know the journey that person's made. If you want to speak while someone else is speaking, raise your hand. The chair will invite you to speak when they have finished. Inappropriate behaviour will not be permitted in this meeting. Individuals will be given 2 warnings, but if they carry on, they will be automatically removed from the meeting. Before I introduce the main speakers, I would like to draw your attention to the online response form, which was emailed to you and is also available on the CHC and Health Board websites and can be downloaded, or if requested, can be sent to you by post. Also, as public bodies, the CHC and Health Board have a duty to take into account the impact of decisions on people with protected characteristics as laid down by the Equalities Act. To assist with this, you are invited to complete the online questionnaire, which has been emailed to you, and email it back to us. I'm delighted to introduce you to Jan Jankowski, the Chair of the Health Board, Dr. Nav Mansani, and Vicky Legrais, who are the programme leads for this piece of work. A record of this discussion has been taken in order to validate what has been said. I intend letting the presenters finish their presentation before opening the matter to the floor for questions and discussions. So please make a note of any questions or observations as the meeting goes along. I would now like to ask Jan to begin the presentation.
Thank you, Chair, very much. And perhaps I could just add to Vicky and Nav the names of Abigail Harris, who's our Executive Director for Strategy and Planning, who's already with us. And also later on, we'll be joined by our Deputy Chief Executive Officer and Medical Director, Dr. Stuart Walker. So, noswetha, croeso. Good evening and welcome everyone to our online engagement event with a very exciting programme of work for us in Cardiff and the Vale UHB. I'd like to thank the Community Health Council for agreeing to host this and the other events that they've dealt with for us during the engagement process and in the future. As a health service, we acknowledge that we do not work in isolation when we try to improve or develop our services to make things better for our patients and staff. We need your support and contribution from our communities, please. At Cardiff and Vale, we are in a unique position in many ways, as we not only provide health services for our local communities across Cardiff and the Vale of Glamorgan, but very often across the southeast region of Wales, all of Wales itself, and in part the UK. It can be a very complicated picture to convey, and hopefully through the presentation and discussion tonight, this will help you to perhaps understand the scale of the challenge facing us as a health service, why we need to change and do things differently, and as I'm sure every one of you will be aware, we are now mindful of the impact of COVID-19 on developing our health services so they're fit for the future. We are incredibly fortunate in Cardiff and Vale to have a diverse and culturally rich population, all with varying health needs at different times of our lives. Our aim is to ensure that everyone has the opportunity to lead a full and healthy life, no matter who they are or where they live. So the provision of future services is vital to ensure that we reduce health inequalities and give everyone that right. Our task is not just to think of providing health services for the future, it's also for the here and now. It's ensuring our decisions are sustainable over the long term and that they can make a real difference to people's health and well-being. We call that improving outcomes for patients and is one of our key principles alongside caring for people and keeping them well. Please make the most of this opportunity to ask questions and get involved. We really need your involvement in these very important but also exciting health discussions on the future of yours and my health service. I'm now going to hand you over to Vicky Legree to take us through the next part of the presentation. Diolch yn fawr. Vicky.
Thank you very much, Jan. I'm just going to share my screen with everybody, and good evening. It's good to see so many people here. I'm just going to wait for that to pop up. There we go. So I'm Victoria Legree, Programme Director for Shaping Our Future Clinical Services. We're just going to take about 20 minutes or so to talk to you about work that's developing within the Health Board at the moment. Most importantly, this includes some changes we're thinking about and what this may mean for you, our public, and also our staff members. And we're wanting to test our thinking really at this very early stage about where and how our clinical services could be delivered in the future, and to get your input at this very early stage in terms of shaping our plans. So there are a number of questions just to highlight on the screen in green that we'd like you to just consider as we're starting to go through the presentation. And there'll be time obviously for plenty of questions at the end. So we launched our strategy as a health board in 2015, and that was really to support us in our mission to care for people and keep people well. But also to support us to deliver our vision of ensuring a person's chance of leading a healthy life wherever they live and whoever they are. And just on the screen there, you'll see sort of 4 key areas to the strategy that we really focused back on when starting to think about shaping our clinical services for the future, but really providing sort of more joined up and integrated care, much closer to people's homes, really a focus on outcomes that matter to patients and are important to our citizens, and then minimising harm, variation, and supporting people to live as healthily as possible and manage conditions wherever possible. So in terms of our services, as a health board, we oversee and are responsible for services not only within specialist hospitals such as UHW and University Hospital Lanark, but across our communities. And Dr. Masani will talk a little bit later about some of our plans for community services in terms of health and wellbeing centres and wellbeing hubs. But we also have a really important role in terms of public health, so promoting health and also a role in preventing that. And the way we deliver our clinical services in the future will have a role to play in preventing poor health as well. I'm just going to remove that off the screen quickly so you can see. There we go. So it's been 5 years and we've made a lot of progress in that time. And there are just a few examples on the screen of how we're helping people to have care close to home, also reducing waiting times for our patients, and developing specialist services for our population. Most recently, that's seen the launch of the Major Trauma Centre as part of a network for South Wales, supporting and improving outcomes for patients who've been seriously injured. And I just wanted to draw your attention to the important point there at the bottom, which is what we've all faced over the last 12 months in terms of the COVID pandemic. It's been a huge challenge, and particularly challenging for our staff who are still working through this at the moment. But what it's done is also provide huge opportunity to really accelerate some of the changes that we wanted to make within as a part of our strategy, and seen huge innovation in terms of delivery of care much closer to home. And that might be through telephone clinics or virtual clinics with the use of digital technology. But there have been loads of excellent examples, and we've had plenty of opportunity over the last few weeks to really listen to a number of our teams, our clinical teams on the ground, and some of the areas which they've been able to really make some real differences in these last 12 months to patients as well, which is brilliant to hear. And really what we want to start to do is capture that, capture those kind of innovations and push them forward when we're thinking about the future of our healthcare. So the case for change, it hasn't changed for us. We are still growing and we're still aging as a population. But we are also, and particularly within the last 12 months, have seen the impact and the increase of mental ill health within our population, as well as a continued increase in long-term illness. We also see a number of health and social inequalities, particularly in our area. We have some of the most and least deprived areas in Wales. We have a real role and responsibility in closing that gap, making sure that our clinical services are equitable for everyone. And so that's hugely important to us. And we're obviously working extremely closely with our partners in Cardiff Council, Vale Council, and third sector voluntary organisations whom we've been speaking to over the course of the past couple of weeks to get their input at this early stage and to work together in partnership. So my screen isn't moving to the next slide. There we go. So we've held recently a number of clinical workshops, which were really well attended from clinicians, senior clinicians and senior managers from across the health board to start to look at how we might start to develop clinical services in the future. And a few big themes really came out quite strongly in terms of our challenges, but also some of the opportunities. The first being workforce, who are one of the biggest employers in the region, 14,000 staff. And have a huge challenge in training, recruiting and keeping hold of really exceptional staff. That's not just a challenge for us, it's a challenge right the way across Wales and the NHS. And that's going to become more of a challenge now with a very, very tired workforce. So we need to think about the way in which we deliver care, the different types of roles and how we can train and really support people to develop within our health service. And our buildings has come up again as a strong theme in order to really provide the care that we want to allow people to recover well and to allow our staff to have a fantastic place to work. We need to look at the buildings with which we deliver care and where our staff work. And in particular, University Hospital of Wales, the largest hospital in Wales, but was planned right back in the 1950s. It's really not fit for purpose. And it really needs to be looked at in terms of how we can deliver care in an improved environment for the future. So we have a real focus on sustainability, which we'll talk about as we go through the slides, but it's hugely important to us. We need to future-proof our buildings as well as our staff. And digital technology is the third large area that came out. We've got huge opportunities for us now. We need to be grabbing those in terms of the way that we can deliver care and the way that we can support our clinicians, our staff on the ground to use that technology. Other areas of exciting opportunity for us are really the development in treatments. So precision medicine we've put up there, it's a really important one. What we're able to do now in terms of using citizens' genetic information to not only treat disease, but prevent disease as well, is a huge opportunity, and there are huge developments in this area. So we really need to consider those now when we're designing care for the future. But also some of our technology, how we can bring diagnostics much closer to patients' homes and into the community rather than having to bring patients into hospital to have those diagnostics. That's the type of technology that's going to be available to us. So again, we need to start thinking about that now. And obviously digital technology, we've talked and we've had a huge acceleration. It's not the right thing for everybody, but there is an opportunity for us to be able to allow patients to receive care much closer to home through the use of virtual and digital technology. And then finally, a hugely important area in terms of our case for change is our role in the economy. We're not only a large provider, but have a huge role in terms of the research and development and our links with the university. We're a key contributor in that area. But also, I know that our health board is hugely now starting to think about our impact on the environment and the climate emergency. We have a role in that, and that is not only to deliver some of the buildings that we work in so that they can be more sustainable, but actually our clinical services being more sustainable and environmentally friendly for the future as well. And on that note, I'm going to hand over to Dr. Nav Nasani, who's going to talk to you a little bit about the new programme of work for shaping our future clinical services.
Thank you, Vicky, and thank you to the CHC for hosting another evening meeting, and congratulations on your stamina for sitting through this so many evenings of the last couple of weeks. So shaping our future clinical services is the emerging and developing plan in order to deliver the objectives of our strategy. And this part of the programme, we're principally talking about services that patients need when they have suspected or confirmed illness and they need investigations, assessments and treatments and ongoing care. It's linked closely to our programme of work in supporting public health with other agencies, of course, and it's linked very closely to integrating health and social care where it's needed. But this programme and the one we're engaging on right now is around the clinical services. Importantly, from the start of this Shaping Our Future clinical services programme, with myself, pretty privileged to be in the clinical leadership role, and Vicky in the management lead position, working for executives who are on the call today. This programme is led by clinicians. So we've got doctors, nurses, therapists, scientists, multiple other healthcare professionals and associated collaborators, third sectors, other health boards, health organisations, being drawn into the programme. We're only at the beginning of that specific clinical services redesign programme, but we've engaged widely with multiple organisations as well as the public thus far, and we can explain that to you a bit later on. Crucially, it's designed for patients, and wherever possible, the patient pathways that we're going to discuss will be designed with patients and with their carers. And we're examining best practice and ways to do that as we speak. Those care pathways have to be home to home, so we have to encompass the whole patient journey to try and break down the silo way of thinking that different organisations can sometimes fall into, and to develop a seamless integration of services where it's needed, particularly for patients with complex care needs, multiple conditions, health and social care, or wider issues that affect their overall health and well-being. Clearly, it is our role to make sure that it's guided by best practice, using the best scientific evidence. There is a role for us to engage and explain that where it's not easy to understand or may even be unpopular, but our objective has got to be world-class standards of care. Next slide, please, Vicky. So I'm just going to explain that in a bit more detail with respect to one large group of future clinical pathways, and this is about planned and elective care. So these are investigations and treatments that are arranged and planned for either the new onset of certain problems or managing long-term conditions. And some straightforward examples, although they can be very complex conditions, would be a painful hip, where you might end up having investigations, assessments, and end up with a hip operation and then rehabilitation afterwards. Or it might be a stomach problem for which you access the healthcare system. Might turn out to be trivial, but it might turn out to be very complex, such as a cancer. So even though these are planned and elective and not emergency conditions, they can still be extremely complex pathways. And I just illustrated the steps through which a patient might go in the future as we design this. For this particular set of pathways, I'll talk in less detail about acute and emergency pathways and also some regional specialist care pathways in the next slide. But for this one, talking to people, staff, patients, what people want is rapid access to efficient and protected pathways, protected from other competing specialties or facilities, protected from infections, obviously COVID, and the development of what we've called green pathways in this pandemic, protected from cancellation, protected from delay, so predictable admission, discharge, appointments, and so on. And these protected pathways can be delivered in new ways that we're trying to embed in our future care pathways, as opposed to just respond to the crisis that we're currently in due to COVID. Wherever possible, we want these services at home or close to home as possible. And we'll talk a little bit about the facilities we're building in communities away from the major hospitals. And as I mentioned before, particularly patients with complex needs, is there something more that we can do to coordinate care, to minimize travel time, minimize discomfort, anxiety, cost of the planet? So these are high-level principles that we are dialing into our design of planned care pathways. And if I just take you through an illustration of how it might look. A patient attends the first point of contact. Traditionally, it's been GP surgery. That's changing already, but some sort of contact in primary care. And now we have multiple ways of, sorry, something's happened to the slides there. Okay. So new ways of having a dialogue between GP and specialist. And we've got certain apps. We've got certain online forms that we're able to consult on a patient in a primary care setting without the patient actually traveling to the hospital. And we've expanded on these in COVID, but again, what we're looking to do is actually embed them into our future care design. That was the beginning.
Apologies, Nav. I'll just
okay.
flip to where we
So
were.
once the patient has seen their GP, that's the slide, thanks Vicky. Once the patient has seen someone in general practice, that dialogue with a specialist may lead to an assessment or a test or even a treatment in a community setting, a community hub. Those things are now linked to the central hospital or specialist service where it needs to be. So there is a requirement here for a digital platform that's fit for purpose. But again, it saves the patient time, money, anxiety, and travel time. We can explain results and make plans with patients via virtual clinics, either by telephone or video, and we're already doing that. Now, clearly there is going to be a need for hospital treatments, hospital assessments, and those are represented by those two little red circles. And what we need to ensure is that that is reserved for when it's absolutely necessary. It's protected for these patients so that that pathway is safe, predictable, and timely. And we're keeping in touch with patients via new methodologies such as patient-reported experience and patient-reported outcome measures, PREMS and PROMs. And we're trialing a number of different apps which allow us to do that for the patients who want to do it that way. And that allows them again to stay closer in touch with us and report back to us without actual, transportation, face-to-face consultation. The follow-up after a hospital episode can be a blend of those different new ways of working. So community hub for what's appropriate there. And that allows for care closer to home, but also integrating health and social care elements where it's needed. There can be more of an emphasis on health promotion in those non-hospital settings as well. And then a blend of virtual clinics, hospital appointments, monitoring alerts to GPs or specialists, GP when it's needed, and so on. And I know that many patients and many carers have already experienced something of this in the COVID year, but that's been out of necessity rather than by design. So on to the next slide, please. So we're considering the same sorts of principles for the emergency and urgent care stream. Now, the question we're being asked here is completely different. We need to deal with life-threatening, life-changing conditions that need immediate and intensive treatments, such as severe chest pain that might be a heart attack, or a head injury that might need a trauma center, intensive care, or even brain surgery. What we need to ensure here is that the patients who need those are directed to the right service at the right time. But patients who don't need those, who need something different have access to 24/7 care, but close to home where it's appropriate, in the community where it's appropriate, and not in a major high-risk setting where it's inappropriate. The challenge for us there is to redesign those pathways, but with a 24/7 equity for patients, facilities, and for staff. And then we have an even more complex challenge when it comes to highly specialised, what's called tertiary services that we offer on a regional or Wales basis. And these are for the complex, uncommon and rare conditions, often which are long-term, and they need highly specialised care. But the principles hold: transport patients when they need to in a timely manner, provide for a resilient, expertly trained and highly skilled workforce when we're talking about relatively small numbers, but we need to offer it across Wales, and deliver these pathways close to home wherever possible using technology or partnership with other organisations. So a more positive approach to working in partnership with other health boards, other organisations, third sectors, where appropriate. And again, as Vicky mentioned, the green banner at the bottom of these slides are the engagement questions that we've asked in the questionnaires, and they'll be flipped up at the end of the slideshow as well. So pathways of care, which I think is recognised across the world as the most patient-centred way of redesigning your services, but in these groupings that have different priorities, different challenges, different opportunities. Next slide, please. I think people are really anxious about where clinical services actually happen. Compared to other areas in the world, we actually are in a small geographical area, but there are clearly differences across the South East Wales patch and the Cardiff and Vale patch, and then slightly different challenges for rural Wales, where we offer regional and highly specialised services. So wherever possible, it is our strategy, and our plan will be designed to deliver care closer to home. There are ways of doing that we can improve upon and build upon, and these will undoubtedly change. Not everyone wants those. Some people do not want access to their medical information via apps. Some people love it. Many people do not like telephone or video consultations. Other people never want to come to the hospital again if it can be avoided. So we need to make sure that we touch vulnerable groups, ethnic minorities who maybe don't converse well in English, people who are in parts of South East Wales or South Wales that don't have access to the digital infrastructure that others do. And whilst we're aware that we're not responsible for the telecoms architecture in South Wales or the transport infrastructure in South Wales, we are aware that we need to work on a multi-agency, cross-organisation way to try and iron out any inequities and offer choice to patients. Health and wellbeing centres are being developed and redeveloped to be fit for purpose, diagnostic and assessment, and where necessary, treatment centres closer to home. And these will actually be clinical facilities. So they'll include some diagnostic testing, and we're working within Cardiff and Vale, but also all Wales is looking at what tools you actually need in these centres, and what staffing and specialist and data requirements for them to be seamlessly working across the piece. And then wellbeing hubs are an opportunity to develop a social and healthcare integration setting. So co-located with the social care localities, our 9 primary care clusters in certain types of integrated health facilities, could be health centres, leisure centres, local authority, community hubs, and so on. And these are areas that will really help us get closer to particularly vulnerable groups, particularly groups who really are at risk of coming to the hospital or cannot come to the hospital. And that is something that we're actively engaged upon as part of our Shaping Our Community Care programme. It is part of clinical services, but it links very, very closely to social care services and the well-being of our communities. And we haven't reached conclusions about exactly what will go where. Again, this is an engagement piece that will inform the development of this plan. And then in terms of the major hospitals, the University Hospital of Wales. Now this is part of our Shaping Our Future Hospitals programme. And our vision is for 2 major hospitals as equal centres of excellence, but with clearly defined and complementary roles, as opposed to somewhat fragmented services, and sometimes the hospitals competing for the same facilities and the same staff group. So this is an opportunity to redesign these big hospital platforms. The University Hospital of Wales has got some specific elements that we are responsible for and we're privileged to offer, actually. So teaching as part of a university hospital for the whole of Wales, not just for Cardiff, and that's crucial to our future healthcare. And also in terms of offering high intensity, high acuity, highly specialised services for the whole of South Wales, for some services, and the whole of Wales for other services. So there's a natural grouping of facilities and specialties and staffing here around intensive care, critical care, and that includes the emergency medicine, the emergency surgery specialties, major trauma, brain surgery, heart attack, stroke, dialysis, and so on. And that draws together certain high intensity specialties with a natural fit. They're interdependent upon each other, and they are codependent on each other as well. So one will not work without the other in some areas. And so we're pulling that together to really try and develop our vision for a state-of-the-art, sustainable and energy efficient facility that will offer these high quality, highly specialized clinical services, but only when it's needed. So if people do not need these, then we will want to stream those patients away from this particular hospital infrastructure. Sorry, can you just flip back briefly? That's probably a clue that I'm talking too much. So we want this to be an ideal healing environment, and we know that it is currently not. And we want it to be an optimal learning environment for teaching and research. And again, we know we simply can't offer that in the existing infrastructure. And then University Hospital Landock is the complement to that. So we talked about what a planned care pathway would look like. Might be very complex. The patients might have equal requirements in terms of complexity, highly specialist, but in that predictable, protected, green zone pathway type of principle embedded into our future care pathways for things like orthopedic surgery. We already tried to do that with CAVOC very successfully pre-COVID. Breast cancer surgery unit, for instance, another exemplar of how you can run that very efficiently for patients if it is protected. But equally for brain and spinal injury rehabilitation, stroke rehabilitation, amputation rehabilitation, long-term conditions such as cystic fibrosis, and mental health conditions where the last thing you want to be is on that hot site, that high intensity site that offers risk, stress, and competition to that healing environment for longer term care or planned care. So again, we envisage UHL as a thriving hospital site, repurposed to some extent for that group of patients. And those 2 major areas of development, plus other infrastructures, have to be considered in the round. We can't do this plan without the communities plan, without the public health plan, without the care at home plan. So they all have to work, and you can't just look at one area without looking at all of them equally. So final considerations for me before I hand over to Abby. We've spoken a lot to our staff. I think that from executive down, it's been an extremely challenging year. And I think it would be reasonable to ask the question why we're doing this now. But what we're hearing from staff and patients is that we have to do this now, actually. We have to start a change, start a movement towards that change. And we've learned so much from the year that it's almost impossible for us to stand still. So we have to take the opportunity to listen to our staff, to develop the sort of services that support them, their resilience, protect them as much as possible, and grow that workforce in the way that they and the public deserve. We are on the cusp of a digital revolution. We've got a little bit of catch up to do, but we're cognizant that it's not for everyone. It has to suit the purposes of the most vulnerable, the those who are living in poverty, those who are living in areas that don't have access to the digital infrastructure that everyone else has. And we are really cognizant of the climate emergency. We're proud, I think, that Wales was the first nation to embed the requirement of considering the environment in all public sector endeavours, and that's the Wellbeing of Future Generations Act. And we have a major part to play, and we think we can, both in terms of just improving things like pollution locally, improving active transport for patients, and cycling, walking, and linking in with plans for transport, even though we're not responsible for it, but also rebuilding health services in a carbon neutral way, which is entirely possible here and now. So there's an awful lot to consider here. And this is the start of the engagement across the entire plan. And in terms of next steps, I'll hand over to Abby.
Thank you, Nav, and thank you, Vicky. So I've got a very short piece at the end of that presentation just to outline for you what happens next. So tonight is the last of our public engagement meetings, but it's not the end of the engagement period. The engagement period runs until the 19th of April. And this isn't the only vehicle through which people can give us their views and share their views. I'm very grateful to Stephen and the Community Health Council for working with us on our engagement plan. So there are lots of opportunities to comment and give us feedback in terms of the questions that have been posed throughout the presentation. So we've already had lots of feedback through questionnaires. We've had those in through a number of different channels. So I think Malcolm said at the beginning that questionnaires have been emailed out to every one of you who are participating tonight. So we'd be really grateful if you would take the time to complete those and get those back to us. We are seeing a lot of interest through social media channels, through our Facebook page, through our Twitter correspondence. And of course, we're using all the usual channels. So using information going out to GP practices, using the footfall coming through our mass vaccination centres. We'll be out in some of the supermarkets in the next couple of weeks to catch people and to ask them to respond to the engagement. The more views we have in the comments, the richer it will be in terms of informing our plans. So when we close the engagement on the 19th of April, we will take all of those views and comments, what we've heard back through all of the different mechanisms that we've been talking to people about these plans. We'll theme those together. We're already starting to get an idea of the sorts of themes that are coming back from the conversations that we've been having so far. We'll share that with the Community Health Council. I think we've agreed a date, Stephen, to do that. With a view that we would then take this back into our board with a recommendation on the next steps to our board meeting in May. And I guess what's important to say that this is not the last chance and opportunity that we will have to engage people in this work. I think as Nav and Vicky have already alluded to, we do have other kind of strands of the work that are progressing alongside this. So we already have a programme business case approved with Welsh Government for our health and wellbeing centres and wellbeing hubs. That work is progressing, and the conversations about how we firm up those plans working alongside this. Nav talked about the importance of primary care. We've got some work happening around how we take forward the model of primary care. Welsh Government published last year a model for primary care. So in May, we'll be reflecting on the engagement in our board and outlining the next steps, and anticipate that we would then develop more detailed proposals of how we might see services change over the next 5-10 years, and what we want to start accelerating quickly in terms of changes that we can start making. So Nav and Vicky's job will be to help shape that clinical plan moving forward, and then to take forward the work on modernising the pathways that have been described by Nav earlier on in the process. So it is quite a complex programme with lots of sort of moving parts in it, and it may well be that we need to do consultation on some of the proposals, and again we'll talk that through with the Community Health Council as we agree the next steps. So just a reminder, we're really keen to hear from you. So from your family and friends, please pass on the word. Our website has got lots of information on it, with a particular page on our website, shapingourfuturewellbeing.com. You can email us at the email address there, or ring us, or use the social media channels I referred to earlier to share your views. So we want to make it as easy as possible for people to share your views. And then just as a final slide, I think is the recap of the questions. But I just wanted to reflect on two things. That in the last few days, the Welsh Government has published two important documents. A document that sets out sort of recovery plan for COVID, so for health and social care beyond COVID moving forward. And it's also published a national clinical framework. And we have been very fortunate that one of our lead clinicians was one of the three a team of clinical professionals, nursing and medical, and others, who informed and developed that clinical framework. So we've kind of got a bit of an inside track on that, and that is very much based on developing pathways in the way that Nav described. So it's very helpful framework for that too. So if I leave it there, Chair, and so we can get on to the questions and hand back to you. But I'm very grateful for so many people joining us this evening, and to the CHE for hosting.
Okay, thank you, Abigail. First of all, I'd like to thank the Health Board for their presentation. It is now your turn to provide comments, questions, and observations, all of which will be noted for reference as part of the engagement process. Ideally, I want to afford all present an opportunity to have their say and not cut short any debate or discussion. I would like us all to adhere to the following requirements. Firstly, could all speakers please give your name, and if you're representing an organisation, the name of that organisation and your position in that organisation. This is purely to assist those taking notes for future reference. Secondly, it would be appreciated if only one person would speak at any one time. This is to assist everyone in the meeting to help the note taker record the question and, importantly, the answer. Thirdly, I would ask you all to act kindly. I'm sure I don't have to ask the attendees to conduct themselves with dignity and refrain from engaging in any personal attacks or aggressive behaviour. Finally, I will invite questions and attempt to limit them to one per person. In the first instance, in order to allow as many people as possible to contribute. I know some of you here tonight were at the meeting on Monday. There's no need to ask the same question again because it's already been recorded. Okay, thank you. Finally, it's my intention to finish this meeting no later than 9 p.m. Could we have first question, please? John?
Thank you, Chairman. I'm Councillor Gwyn John from Lantford Major, and I have already had some of the treatment that you all talk about this evening. Basically, I attended my GP with a problem with my throat, and I was referred to Princess of Wales Bridgend, and within 4 days I had a letter from Princess of Wales asking me to go for blood tests and enclosing the necessary equipment. I made my own blood tests within 3 days. I then waited to hear from the hospital. I went back to my GP and checked after a week, and he told me, "You're dealt with by Princess of Wales now. You'll be under them. They will deal with you." And sure enough, I then had a call from Princess of Wales asking me to go in for a CT scan. I had the call on the Friday. They wanted me in on the Monday. I was there on the Monday morning. I had the CT scan, and then within about a week to 10 days, I had a phone call making an appointment for me on the phone with a consultant. And the following Friday from that phone call, I had a meeting with the consultant on the phone. It saved me going into the hospital again. It was a chat on the phone, just like talking to your next door neighbour, as if the consultant had known you all his life. And quite honestly, it was excellent. He prescribed the necessary medication to my GP, and away we went. There was no problems whatsoever. It was excellent. And if this is the type of work we're looking towards in future, it saves time hanging around in hospitals, traveling to hospitals. And if you can work from your own communities through the medical centers, hubs, etc., and I don't see any problems at all going down the line. Another point with me is that I've got hearing aid problems. I'm deaf completely, so I've got to have hearing aids. And since the West Key opened in Barry, I've gone there regularly to West Key surgery whenever I need to. I was originally back in the 90s going into the Heath, but it's a long way to get to the Heath from Lantford Major. It takes time, parking, and down to Barry, 20 minutes. I make the appointment in advance, my time, and in I go, an excellent service again. So I think we're going in the right direction, sir. You know, we've got to wake up. We've got to be looking towards a modern structure. It's not a day out in the hospital. And I think we need to, with people, they're more happier working from home than being stuck in an ambulance and spend a day down the hospital. And they don't achieve very much sometimes because they see a consultant who says, thank you, Mrs. Jones, for that, blah, blah, blah. And you don't need to come to see me again. Well, surely a phone call can save all this. And I think the way forward, we're going the right way. So I am very happy, and I hope that in the future we will have a medical centre in Lantford Major that we can set all this up in the Western Vale. We got a population growth in our area in the regions of 25,000. So it's certainly, thank you for your time. Thank you.
Thank you, Gwyn. Has anybody got an answer for Gwyn? I don't think he.
Chair, very briefly, I've put a comment back in the box. It was very good to hear Gwyn's experience, and you're right, those are the sorts of models that we would like to do more of, and if we can shorten the pathway even more. I'm conscious that Dr. Stuart Walker, our medical director, who had another commitment earlier on this evening, has joined us, and I think he might want to respond as well, Malcolm. But certainly, Gwyn, really good to hear your experience, and the feedback about video or telephone consultations that we've had is generally very positive. But over to you, Stuart.
That's fine. You've replied, Abby. I don't need to add anything else further. Thank you.
Okay, can I bring Barbara Chidgey in next, please?
Sorry, right, I've just unmuted. Thank you very much, and thank you to everyone for their presentations. I should say, amidst other things, I'm a Bevan advocate, so I do tend to speak up quite a lot on behalf of patient experience and voice and so on. And that's really what I'd like to bring to this now. I totally agree that a totally important resource is the NHS staff, but actually all of us as patients are part of the solution, and we should be equal to the NHS staff. And I want to take 2 points from that. One, about how can we link the community hubs, wellbeing hubs, to primary and secondary schools, and I'll explain a bit more in a minute. And secondly, how can we look at perhaps bringing in medical mentors, I'll call them, to work equally with patients who have multiple complex comorbidities. And finally, I want to plead with you, please, can we get rid of the cartoons? I feel trivialized by your use of them. So let's put that one to one side. Primary schools, secondary schools. When in talking about health, we want to work from cradle to grave. The trusted relationships and where every parent goes is into a primary school. So can we extend the community and wellbeing hubs to build in the good relationships at primary school, the trusted ones? So if a teacher says to a parent, I don't think your child can hear very well, and helps them get to the audiology clinic, So from very early on, what we're doing is working on relationships and mentoring and guidance, which provokes well-being rather than managing ill health. So that one I would like to put in. Can you be a little bit more creative about the community and well-being hubs and work with education? There's so much scope. And the second one in, I am a patient with multiple comorbidities. I almost feel embarrassed by the amount of clinical specialty areas with whom I've got a working relationship. But the reality is our system today means all the specialities are in silos. And actually what would be brilliant is, putting the clock back, think of my parents, they liaised with like a physician who acted as the key person who took all the information from whoever it could have been, whichever clinical specialities, and discussed with them the way forward. They were equal partners. And I think for those of us with comorbidities, and we're huge numbers, including all of those who are now just added to that with long COVID, the kind of support services long COVID needs are very similar to those that people with lupus, with ME, with chronic fatigue, with fibromyalgia, and you name it, need. So I want to throw that one in as well, because it is about managing well-being, not just managing illness, if that makes sense. Thank you.
Okay, thank you, Barbara. Stuart, do you want to come in on that one? I noticed you were on the chat.
Coming on the second point, if I may, and I think, you know, the multiple stakeholder involvement, including education, is key, but it might be other colleagues want to comment about that more than me. But in terms of the second point, I think, Barbara, you've picked up a very clear national direction of travel there, and I think it is clear that the provision of healthcare services in the UK has risked being too specialised and individuals becoming too specialised, and that there is a clear need for the generalist. So you're not alone in making that point. It's the same point made, for example, by the Royal College of Physicians about exactly the issue you described. So I think you're right. I think there is definitely a need for that, and as part of our shaping our future clinical services work stream, there's absolutely a need to get that balance right between our super specialists all the way through to what, you know, you've described quite accurately as a sort of good old-fashioned general physician. And I know, as one, I'm accredited as a general physician, as well as a cardiologist, that it's a key role. And I think, you know, we need to really make sure that people take that up as a career option, and that's something we absolutely recognise. It is a direction of travel, but it's a really good point. Thank you.
Yeah, and just picking up on the partnership issue, Barbara, I couldn't agree with you more. One of the things that we're doing with the two public service boards is really trying to make sure that we do that join up between public sectors. And we've got some pockets of that where we're working very closely with schools. And as you say, we've got a captive audience there, and we're doing work with you know, the broader families connected through schools. And we'd see that being very much part of our thinking around not just the physical building of the health and wellbeing centres, but actually how we reach out into communities and make connections between community groups. And we've got some really good examples where we're doing intergenerational work with children as well. So they are working with our older population, as well as obviously working with the families. And we recognise that children are quite good messengers in terms of some of the health improvement work. They're quite often very good at taking messages back into their home that they've picked up in school. So we've got one of our colleagues, colorectal surgeons, doing a lot of work and set up a charity doing work in schools to engage people in talking about bowel cancer, because it's something that we kind of generally might not want to talk about, and really working with children and young people about those messages so that we can have those conversations in our families. So that's just one example, but completely agree with you. That's a really important opportunity. We've got a really thriving youth board. I know Nav and Vicky spent quite a few hours with the youth board the other day, and we've been out to talk to the youth board in the Vale with the Vale of Glamorgan Council, or the Youth Council, sorry, in the Vale. Again, really recognise that younger generation have got a huge amount to contribute in terms of our thinking, but as partners in this. And I just wanted to then come back to the final comment that you made right at the beginning. You said something really important, Barbara, about patients being equal partners. When we developed the strategy that Vicky referred to, Shaping Our Future Wellbeing, back in 2015, we started that work with lots of conversations about people who use the services and what was really important to them. And actually, I just got up on my iPad the original document, and one of the key strands in that is to promote equity between the people who use and provide the services. So that is a theme that comes through really, really strongly. I'm just wanting to link back to Gwyn's comment, because one of the things that we're hearing about things like video consultations and different ways of delivering services is that some people have kind of reflected that actually having some of those kind of clinical conversations in the comfort of their own home with their loved one sat on the sofa next to them kind of changes the balance, the power balance a little bit, rather than going into kind of quite a clinical environment. So there's quite a bit of research and learning, and we are contributing to a big national programme at what we can learn from delivering services in a different kind of way, because I completely agree with you. That's exactly what we want to achieve. And it's also what we want to achieve in terms of joining up with health and social care. And I know that you know that there are challenges in terms of ensuring we can meet everybody's needs, but again, trying to make sure that we're really engaging with people about what's important to them and not assuming we know what's important in people's lives. You know, what is important for them, what are the most important outcomes, what's the things they want to be able to do and to achieve in their lives. And again, that features very much as part of that wider work we're doing on shaping our locality model, talking to people about what's important to them, and features as part of this programme too. So they were really important points, Barbara. Thank you for raising those.
Thank you, Abby. Can I bring in Hannah Wilton next, then followed by Trevor and Christine Netherway afterwards?
Thanks. I'd like to echo Gwyn's comments a little bit, that the experience I've had of healthcare, particularly within the telephone conversations during COVID, has been exemplary. I think the form that's been used online, that you fill in all of your details and your concerns, takes you through what's happening, then you submit it, and then you get a phone call from the GP, really allowed the GP to assess the situation and look at my notes and bring those two things together and kind of get to the point much quicker. It was the best consultations I've had with GPs ever during COVID. So, you know, I think it would be a real shame to move away from that. I think it's been immensely helpful. I've written my note down here somewhere. One of the things that Nav talked about was changing clinical pathways and bringing patients into hospital when they need to, but making sure that that's followed up afterwards. He mentioned in community hubs where appropriate, or in hospital where appropriate. And I think that's one of the key things about decision making for me that I'd be keen to learn more about. Who is going to make that decision about where it's appropriate? Now, I understand there's going to be issues with cost about replicating clinical equipment, for instance, in multiple localities, that might be prohibitive. Also, with enormous amounts of respect, you know, clinicians and healthcare workers, myself being one, can be quite resistant to change and may immediately say, well, we can't do it like that, rather than the other way around. How is that decision going to be made? Is it truly going to be driven by patients? And if so, how are you going to do that? Because this engagement event is fantastic. I'm so pleased that you're holding them and that we're invited, but there's 32 participants on the line and I've counted 7 staff from Cardiff and Vale. So there's not actually that many of us from the Vale here tonight. How are we going to get that message out for people to really give their opinion on how we should be changing these, taking things forward?
Nav or Stuart, do you want to talk about the clinical decision? Because Nav, you might want to draw on some of the experience of where we're already sort of doing clinics out into primary care, whereas before, and you're an example of that because you do it, where previously you delivered in hospital. And then I'll perhaps draw on another experience, an example of where actually thinking has moved on in the last little while about where you might receive things. So do you want to kick off first, Nav?
Yeah, very valuable points, and thanks for the positive feedback, Hannah. So in terms of where things will be, because I think we are embarking on a fairly transformative and system-wide or whole pathway programme, we do have an opportunity to move things around, to change the way we're doing things in a planned way. If you've already got infrastructure in place, and importantly, you've already got staff in place, it's more difficult to make a small isolated change. But if you're doing it in a wider systematic approach, I think there's an opportunity. So I hope that major cost won't come into it. It's about getting the right things in the right places. Some of them are technical in the sense that it is just not possible to locate a specific facility in multiple different places. I think a bigger challenge, actually, you touched upon it, is workforce, because patients don't like change in terms of, well, I've always had my consultation here and I don't want it done there. And you know that if any major change is being undertaken in a certain region, there will always be a backlash against that change. But it's the same with staff, because our staff have told us that, you know, I work in this location. It means I know how to get to work. I can pick up my kids after work. And if those locations change, these are very real issues. So we're going to have to do it with that public partnership, but also with staff partnership. And I think that refashioning the workforce to work in multiple locations is probably going to be a bigger challenge than the financial implications of that. So again, I think you can only do it by design, and you have to have an appetite for change. And I think perversely, perhaps, or unusually, the sort of change that you and Gwyn have just talked about in terms of accepting things that were really quite new in our ways of thinking, the pandemic has actually really kind of stoked that appetite for change. So I think it will be around, you know, what can you actually do to the highest quality? So if you can get a particular scan in the hospital location, and you can have the scan in a local hub, but it's not going to be a sufficient quality, then we've got a challenge, haven't we? Either we don't offer it, or we have to skill up that local service. So Abby's right. I've done a community cardiology clinic where part of the team, myself included, go and do a specialist clinic, but in GP practices, actually, in partnership with a GP. So you're making a change there. People talk differently. People can park. People can access it easily. But we did have to take equipment out to it. And the equipment, by its portable nature, not quite as good, perhaps, as some of the other things. So there's a multifactorial element there about what's feasible. But the principle here is to move as much as possible close to home. Okay.
Thanks. Sorry, Nav.
So as far as possible, that is a key design principle, as is involving patients in that dialogue. So these are key design principles for the whole programme. And Vicky and I respond.
Abby, I wonder if I could just add, sorry, Nav.
Yeah, go for it.
I wonder if I could just add on that. I think the one thing that's been really powerful for us in terms of engaging with people is sometimes the access to the data that we can get now and the information. I think this is a part of the reason also for looking at whole pathways. We've done a number of things more locally with a team to look at the integration between primary and secondary care, opening up the discussions on different pathways. And that's been something that's just been happening sort of internally and looking at small changes. But actually the use of the information about what impact that has for patients, but also on cost and for staff has been really powerful, because if you move something in the system there, you're able to see with the information along that pathway what that means at the end of it, or what that might mean for staff. And I think we're really keen that when we look at all of these pathways, we map what currently happens for that person right the way along their journey and for the staff. And then any changes that are made to that, what does that mean? What would that mean for patients? What would that mean for our staff? And I think that's something we don't often do, because we look at silos in terms of what it means for general surgery or what it means for general medicine. So I think this is quite a different way of looking at it. And I think we're going to have a lot of people on those pathway redesign sort of workshops as we start to look at the pathways. And we're starting to think now how we apply the data and the intelligence to that, so that we can look at what the changes will actually mean in real time as we're planning them, and have the discussion very, very openly with the clinical teams and the staff who are on the ground, because they'll need to be a part of it, as well as with people who'll be using the service. So I think we've got much more access now to some rich data from sort of health, which we can use to help us with discussion, actually.
And just to finish off on that, I guess, and I hope that Vicky and I are going to be a really good team. We've only just come together, but we finish each other's sentences, so that's got to be a good start. So one of the other issues, I think we do have to be change that relationship with the public, so that if we are making a change, or if we're not making a change that might on the face of it seem an obvious thing to do, then I think we need to be really clear about why we're making those decisions and engage in a much more active and two-way kind of process. So if we're unable to make a change that the public would think that should be done, then I think being able to explain that more clearly and why you might need to go to that big old hospital for some things in specific instances or not has to be part of that pathway redesign dialogue with patients. And we're building up a pretty big stakeholder map at the moment, and we've also got teams that do that, and we're designing these designing the methodology for pathway redesign as we speak. So it's early stages. I think Abby wanted to just say one specific as well.
Yeah, just very quickly, because I'm conscious there'll probably be lots of other questions. Two final things I'd add to that, Hannah. Just a very specific example. We know that there will be people who need to go and have surgery, and sometimes that will be quite complex, and that will need to happen in a hospital. But what we do know is that we can do better at getting people fit and ready for their surgery. And we've got a really nice case study of a gentleman who was one of our patients' stories in one of our health board meetings. We start all of our meetings with a patient story, and he described the experience of a new service we'd wrapped around when he had a diagnosis that meant he required surgery. He talked about, how can I make sure I recover as quickly as possible from the surgery, and how do I make sure that the thing that required me to have the surgery in the first place doesn't come back. And we did something called prehabilitation, so really focused on maximizing his fitness before surgery, so that he came in for the shortest possible time, had the surgery, went out, and we captured what was called a teachable moment, where he changed his lifestyle at that point, and then became a very fit, healthy person afterwards, because he recognized he didn't want to come back and have more surgery again. And that's not everyone's experience, of course, but that really for us is how we would see wanting to make sure the best possible outcomes for surgery. And one final example, when we started work on our health and wellbeing hubs, which was about 5 years ago, when we started shaping our future wellbeing, we wouldn't have considered talking about putting a CT scanner in our health and wellbeing centres. We are now having that conversation. So Gwyn, next time you have one, it might well be that we're delivering those in our health and wellbeing centres. So certainly something that we're thinking about at the moment, because the technology's changed, the kit isn't quite so big and cumbersome, and there are different opportunities. Chair, I'm conscious that was quite a lot of answer in there. So if I pause there and you might want to pick up another question.
Okay, thank you. Trevor and Christine, do you want to come in now?
Can I ask two quick questions? One, I didn't see any mention of maternity services at all. Can you briefly explain how and where you expect those to be delivered? And secondly, I didn't see any mention of volunteers. Do you see a role for volunteers in this service anywhere, please? Thank you.
Thank you, Christine.
Yeah. So in terms of the major bundles of care, there is an entire work stream on women's and children's services. So yeah, and it'll be the same design principles. I mean, we're taking care not to sort of be presumptive and finalize plans on anything. There are certain maternity services, as you will know, that do require 24/7 high intensity, high acuity services, and there are others that we will be delivering hopefully close to home. So it will be the same principles applied to the entire maternity services pathway, and of course also regional specialty, where we offer highly specialized maternity services. In terms of pediatric services, well, once again, I mean, we do have a Children's Hospital for Wales, so that is one specific entity that already exists. And so that is a fixed infrastructure. But in terms of the ways of working, again, we will be working with the children's teams on exactly the same pathway principles. So there is more to the pathways than I explained, but I think the principles were the important things to try and get agreement on. And then in terms of volunteers, yes, we have done a lot of engaging in the last couple of weeks. We've spoken to a whole range of different organisations, and we're working our way through those people that we would want to form partnerships with. So third sector and voluntary organisations are on our list, very much so.
And just to add to that, we are really fortunate that many people already volunteer their time to work with us. So we have a rich programme, a very extensive programme of enabling volunteers who want to come and volunteer and work with us to do so. And I don't know whether you saw today, Vaughan Gethin was down visiting the Bayside Vaccination Centre, the new mass vaccination centre that we've developed in the Bay. And we couldn't deliver those things without volunteers coming forward. And I guess what we've seen right across the board with public sector partners and our local authority partners in particular is people willing to give up time and wanting to contribute in their local communities to things that they think will help people's health and well-being. So we're really lucky, and we will continue to build on that because the experience is very positive for us around that.
Okay, thank you, Abby. Can I bring in Eleanor Landag next, followed by Emma Proctor?
Well, hello, everybody. I should say I'm actually an employee of the Health Board. I'm a clinician in the Health Board, but I'm here as a private citizen this evening. I'm really interested to hear about the changes that you've outlined, and I think in general I approve of all the principles behind them. I think as a clinician I can confirm, obviously, the last 12 months have been a really big catalyst for change, and it's really helped us to identify opportunities for change and force us to adapt and change very rapidly. I happen to live in the very western part of the Vale, and I'm wondering about how the changes proposed will work in the rural Vale. So, you know, we heard from Gwyn about the great service that he was offered just over the border in Bridgend. And at the moment, lots of people who live in this part of the Vale go to Bridgend for, you know, healthcare and well, lots of services really. But I'm wondering how healthcare closer to home will work for us out here. We don't have many big population centres, and I feel that it could be a challenge in providing an equitable service for people in this part of the Vale. Because, you know, for example, for us to attend a hub, we're probably likely to either need to travel into Bridgend to the hospital or to a hub further east in the Vale. So my question is really, how is this going to work for us out in the rural Vale? What can we expect to see? But also, how is Cardiff and Vale Health Board working with other health boards in South Wales to deliver this vision?
Thank you, Eleanor. Two really good questions, and Stuart probably will want to add to this. So two things I'd say. First of all, we're working very closely with Cwmtaf Megannog on our boundaries in Bridgend and to the north of the Vale. I was on a call this evening before I joined with my counterpart there, the planning director, and we working very closely. And they were talking to me this evening about their clinical services plan and developing their own strategy and how we could make sure that dovetails together. And the comment I would make around where patients flow and the kind of local provision. Clearly, we've got a very active cluster in Western Vale. It might only be 3 GP practices in the cluster, but they're really keen to kind of develop the concept in Cowbridge and in Llantwit Major. So we are working very closely with them, and absolutely right. There are things we can be delivering in a small community, perhaps not everything, but we're certainly working very closely with the GPs and having some really positive conversations. And we've already done a little bit of work to further develop the Cowbridge facility and building on that. And of course, for some patients, the pathway that the GP will follow will be into Bridgend, into the Princess of Wales Hospital, if that's what the patient wants and it's more suitable. Stuart, do you want to say a little bit more about this, the work we've started with Cwmtawf Morgannwg in terms of that partnership?
Yeah, I think the general point is that we want to make sure that this whole set of works involves all of the stakeholders that might need to be involved to get the best possible design of the service. We are not an island, and we need to make sure that our neighbouring health boards, Welsh Government, university, education, local authority, ambulance service, etc., are all have a say in how we develop our services. And of course, we recognise the fact that within the geographic footprint we're responsible for, some of the services provided to people who live in our footprint are from neighbouring health boards and vice versa. And what we're doing, we're not trying to put a wall up around Cardiff and Vale and design a service within that only our population can access, and that people can't get out of that either. No, not at all. We're quite the opposite. We want to develop an integrated service that works well for us and all our neighbours as well, and not least of which because it's the right thing to do, but also because of our role as the University Hospital of Wales, and the need to really make sure that alongside our primary care services, mental health, community services, that we get our tertiary services offer right as well, and that's not something we can do in isolation. So it's a really good point, and hopefully that's given some clarity to you, Eleanor.
Okay, thank you, Stuart. I'll bring in Emma next. Just before Emma comes in, there's some bits going on the chat line. We are actually recording those chats, and we'll say those as part of the evidence going forward. So some of your comments will be added to it, and if there's been a reply to it, we will add those to it as well. So please continue using the chat if you want as well. Okay, Emma.
Hello, I'm Emma Proctor. I'm the business partner at Lantwick Major and Coastal Vale Medical Practice. So you've got at least one primary care representative, non-clinical, I might add, on this chat tonight. We've got circa 11,000 patients, and we cover 3 sites, Lantwick Major, Roos and St Athan. So we're very interested on ensuring that we're involved in this, looking at integrated service provision. We've already seen a lot of changes, not pre-COVID, just in terms of we've got MSK now in our practice, mental health services. So there were a lot of changes that were happening before COVID arrived, and then since then, like yourselves, we've been working differently, using the technology. Pleased to hear the mention earlier from Hannah about e-consults. I know it's not for everybody, but again, our clinicians have had to get used to how we use that as well. And we've also seen things such as looking at our asthma reviews. We've done more asthma reviews in the last 12 months than we do normally. And so it suits patients with respiratory problems that we can't normally access, especially the younger patients who are at work, who can't attend for their annual reviews, don't see the importance of it. We're now being able to engage with people we haven't been able to engage with previously. So, there have been lots of new ways of working that, certainly I was astounded when we saw the figures. Even our diabetic reviews, we've got 800 diabetics. It's a massive number. We've got a very high elderly population, and we're continuing to do their annual reviews. So we're working differently, but we are still trying to provide, the same high quality level of care. So we want to be involved in this journey. It was interesting, Eleanor kind of stole my thunder, because I was going to bring in the cross-boundary issues, which continue to thwart us. We're 11 miles away in Lantwick from Princess of Wales. We're 18 miles away from the Heath or from Clandalk. So, we need to make sure that, any services that Cardiff and Vale are looking to bring closer to home, if they're going to be joined up with secondary care, we need to understand the implications on those for our patients. We cover 100 square miles. It's a huge area, which places a lot of demands on our clinicians as well for how we deliver care. But certainly we've been continually developing our own premises, trying to keep modernising them. We're looking again at how we can modernise our site. And we want to make sure that we can meet the needs of our patients. And they've certainly changed a lot in the last 12 months.
Yeah, thanks Emma. If I jump in and then others can as well. Well, thanks for the comments. And obviously, we're aware of all the positive work that you're doing and trying to capture best practice and good practice wherever we can. Involving primary care is absolutely crucial as part of that, whole, home-to-home pathway, future care pathway redesign methodology. And we've been having quite extensive discussions with our primary care PCIC clinical board, and also with individual people who work in the primary and community care settings. So there's two pieces of work going on there. There's the clinical services, but there's also the care in the community, shaping our future care in the community piece. So there's a couple of different things going on. It probably is slightly easier engaging with hospital teams because we're all in many of us are in the same location and work in a similar way. So trying to get primary care in the same meetings and things like that is probably easier now that we're working on Teams and Zoom rather than in conference rooms. So I'm pretty encouraged actually by the levels of engagement and positivity we're getting from our discussions with primary care. So just to rest assured, we haven't actually had a single pathway redesign workshop yet. We're just setting those up where we are picking from best practice, and they've not all come from hospitals by any means. Optometry have got some amazing pathway redesign work ongoing. And they are, incidentally, they're also independent contractors, like many GPs remind us that they are as well. So the pathway redesign could be led by independent contractors if that's the right thing to do. So we're picking up exemplars, and we'll be trying to spread and scale, to use that terminology, basically picking up best practice and embed it in the methodology that we spread across other pathways too. So that's an answer for in terms of engagement. The other points you made, I think, have already been answered, and they're points well made.
Thank you.
Right. Are there any further questions? Anybody like Rob? You're on mute, Rob.
Thank you, Chair. Rob Henley, member of the Cardiff and Vale Community Health Council. I guess one of the aims of any health service is to get the public to stay healthier longer. Certainly something that Mark Drakeford worked on. So just wondered whether the UHB has a public health program so that we can detect the patient pre-symptomatically or patients of early stage disease and then treat. So my question is really, what is your public health program for the community?
I think Stuart wanted to come in on that one.
Yeah, I'll come in on that. Yeah, very, very active public health program, Rob. And I think, what the different components of what you said, you spoke about population health. So the need to keep people healthy with the public health measures that we all recognise, such as smoking cessation, weight control, physical activity, and so forth. You then spoke about identifying illness early, which of course would be so pre-symptomatic illness. So that would be part of the screening programs that you see. So things like breast screening, colon cancer screening, and so forth. So there is there's a very, very active set of works looking at that. And what we haven't done tonight is specifically focus on those. They are an additional component to the list you see behind Nav, Vicky and Abby, which is related to shaping our population health. Yeah, it's a very active work. There's a strategy which is in development, because strategy is always in development, because they're always, you know, working so many years in advance. And in terms of delivery, a hugely efficient and high quality service. Of course, it goes without saying that our public health colleagues have been rather busy in the last year in terms of dealing with population testing, delivery of vaccination, et cetera, for COVID. So, you know, we do have to cut them a little bit of slack in terms of quite how far the strategy has got in the last year, but yeah, very active.
Okay, thank you. I've had one question sort of coming in about community hubs. You know, have a little bit more information about the concept, what they involve, and also they live in Western Vale and in Llantwit. Will there be one close to them or in Llantwit?
So we haven't designed all of the programme around our health and wellbeing centres and wellbeing hubs. As I mentioned briefly before, that'll be work that we do very closely with our primary care clusters for Western Vale to work out, building on the existing primary care centres, what more could we provide locally and should provide locally. So there's an opportunity to influence that. So the sort of process we would go through is talk to people in the local community about what would work, what would be complementary to what's being provided in primary care, and how could we bring services together in a slightly different way. So if people have got specific ideas and examples, fill in the forms and include those in some of the text that you can contribute in the questionnaire, and we can pick those up as part of the next phase of our work in development. Just to give you an idea, I think on the slides Vicky talked about Malva. So Malva is in Eastern Cardiff, in Llanedin, and is our first wellbeing hub, where we are replacing a GP practice and we are co-locating a development. We're building on the back of the council's community hub there, and so that there's going to be a single front door. It'll have a whole range of community services, third sector services, the council services. So if somebody's coming to the GP and actually one of the contributors to their anxiety is about their benefits or their housing tenancy, or might be something that a third sector provider or a peer support organisation might be able to help with. It's all in the same building under the same roof, and will provide easier access. So we're really pleased that the Minister approved funding for that not that long ago, and the diggers were in the ground, I think, 2 weeks ago. So not everyone will be the same. It will be very much dependent on what the local need is. And the idea is that we would have one of those per cluster, and we've got 9 clusters. So we've got the first one in Malva going. We've been discussing with the local GP practice and the local authority the plans for Eastern Vale in Penarth. That was triggered by a GP practice that needs new accommodation, and we're in discussion about the plan in Ely. So we're rolling across the patch and we'll pick that up, but really keen to hear people's views about what could be provided locally, and as we get to the detailed planning of that, we'll be out talking to local communities around that.
Okay, thank you. There's a lady who's showing up as iPad, if she'd like to come in.
Yeah, sorry, I don't know how to change that. It's Doris Dallimore. I'm a member of our patient participation group at the North Cardiff Medical Centre. And I'm also on the Cardiff and the Vale Expert Carers panel. So my first point really was just to raise awareness that carers have been mentioned once tonight in the presentations, but just really a plea on behalf of all carers to make sure that they are involved along with everybody else and patients. And following on from that, an example really, somebody in our family has been very ill since Christmas and has had some surgery and various hospital appointments, but as much as possible has been done via virtual consultations, and it has actually been so satisfactory, so helpful to the family, and the person who's actually the carer has benefited so much for from actually feeling able to ask questions. And I think that's really important. I think sometimes people are inhibited in face-to-face consultations in a clinical situation. And the other thing I wanted to say, that there's an awful lot of positivity here. Very sad in a way that a lot of it has come out of what everybody has gone through in the last year with COVID. So a lot of the developments I would feel very, very positive about. Obviously, because I'm involved in our medical centre, I'm particularly interested in the fact that they're going to be the wellbeing hubs for the 9 clusters of primary care. And just as an example of how people would get involved more locally in things like wellbeing, we organise events from time to time. Sadly, we haven't done one for a year, but we've had an event for carers. We've had a diabetes evening where we've invited organisation and had talks and organisations to give advice or chat to somebody else about what they find useful, or that kind of thing. We had one for thyroid issues, and we had over 90 people turn up that evening. So people will turn up locally. And also on our patient participation group, we've been looking at things like developing walks to help people with rehab when they have had immobility or surgery. So things like that, I think, would translate very well to the wellbeing hubs within the 9 clusters. Thank you.
Thank you, Doris. Anybody
Fantastic. Thanks, Doris. You're on the team.
Okay, thank you. Has anybody else got any questions they would like to raise about the presentation, or any issues raised in the presentation? Just wave at the screen if you have.
Chair, we're over 2 screens because the number of people who are online. So I'm just checking both screens, make sure nobody's waving and they're being missed.
Yeah. Yes, I didn't say no. Okay, so it's the last chance for anybody to raise any further questions. Okay, well, if that's the case, then rather than sitting around for the next 25 minutes staring at each other, I'll bring the meeting to a close. So we've come to the end of the online engagement meeting. I wish to thank the speakers for their input, and also the clinicians who have taken part. But I especially like to thank you for attending and feeding in your comments, questions and observations into the meeting. We will ensure that all the views, comments and observations you have expressed will be taken into consideration in the discussions that the CHC will have following the end of this engagement exercise, in order for the CHC to formally respond to the Health Board. Could I also remind you to take the opportunity of having your voice heard is to complete the questionnaire and return as indicated on the form. Finally, thank you all once again for attending the evening. Can I ask Jan, on behalf of the Health Board, to say a final few words?
Thank you, Chair. Thanks very much. And perhaps I could echo your comments and express my gratitude as well for everyone who's turned up this evening, given up your valuable time to contribute to this very important shaping of our clinical services futures. And it is the word shaping that I want to re-emphasize with you. We can't do this without you. We won't do this without you. It's really important that you have your say, please. And there's been so many good points made this evening that we'll record and include in our assessment process. So I'm very grateful for that. Please ask your friends, your colleagues, anyone you represent to have their opportunity to express their views as well, please. We need as many opinions as we can possibly get as we try to build our services around our patient, rather than making the patients travel all the time to an appropriate venue. So we really want your views and your insight, please. Thank you very much. No star. Good night.
Thank you. Goodbye, everyone.
Goodbye.
Bye-bye.
Thank you. Good evening. Bye.